And welcome to the Dr. Bob Show. Almost everybody is afraid of getting a stroke, of having the problems with long-term rehabilitation, long-term physical therapy to just learn how to do regular tasks. Over the years, the treatment and the physical therapy has gotten better and better, but we're going to be talking on this show about what I think is one of the newest and greatest advances in the treatment of stroke. It will be called Interventional Neuroradiology. Well, my guest is Dr. Keith Woodward. Dr. Woodward is a board-certified radiologist. He has also had special training in interventional neuroradiology. He's going to talk about the very newest treatment in the treatment of stroke. Hello, I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about the importance of the adrenal gland and how it affects your body. And atrial fibrillation. Most of us have heard about AFib, but we're going to talk about why it's so dangerous and why it's dangerous to your health. A lot of information for you. You'll want to stay tuned. We're talking with Dr. Keith Woodward, board-certified radiologist, board-certified in neurointerventional radiology. We're going to learn about what that is and how it can prevent somebody from having problems of a stroke in their recovery. Keith, welcome to the Dr. Bob Show.
Thank you so much for having me.
First of all, what is a stroke?
A stroke can be of two types. A blood vessel that takes blood up and oxygen to the brain can either be blocked, so that part of the brain can't get oxygen. That's what we call an ischemic stroke. Or it can be ruptured and bleeding, and that's what we call a hemorrhagic stroke.
So we've got an ischemic and a hemorrhagic. Are they easy to differentiate?
They're very easy to differentiate. A basic CAT scan in any emergency room will tell the doctor quickly if it's ischemic or hemorrhagic.
And what are the symptoms? Are there any keys to, I think I'm having a stroke, or I think my neighbor's having a stroke? What are some of the symptoms?
We talk about FAST as a mnemonic to remember. So FAST, if you see someone who has facial weakness, weakness in one arm, or if they have problems with their speech, face, arm, speech, time is brain. So the T is time. Call 911 as soon as you see any of those symptoms so that we can quickly react to that.
So what does the face look like? If somebody has a stroke, what happens with the face?
Typically you'll see asymmetry or weakness on one side. That's the most common thing.
Is it usually the one side of the mouth will droop or the other when you smile? So you tell somebody to smile, or let me see your teeth, and one side will droop.
Correct, or open your eyes and you can't open one eye as well, correct.
How about the weakness in the arm? How weak does that get?
It can be anything from completely unable to move that arm, or if you ask them to hold up their arms, they can't move it, or it may be something where they can only get it partially up. It may be partially weakened.
It must be interesting to see the different variants on that. In speech, what's it sound like?
We see two different things, typically slurring of the words, where these words are all slurred and they're hard to understand, but they're the right words. And another word we call is called aphasia, which means they can't say the right words. So the words make sense, but they don't go together and they're not the right words.
So if you see those symptoms, you call 911?
Call 911.
Get to the emergency room right away. Does the ambulance or the emergency medical transportation, can they do anything on the way to the hospital to help the doctor?
They can determine if it's what we call a large vessel stroke or a bad stroke. And if they see in the field it's a bad stroke, they will take the patient directly to a comprehensive stroke center. And that's kind of a big fancy word for a hospital that does all the things that neurointerventionalists do.
Neurointerventionalists, and we're going to get into that in just a minute. So when somebody gets to the hospital, is there anything you have to do to make the diagnosis? Yep, this is a stroke.
We do that CT we just talked about to see if there's any bleeding. Is it a hemorrhagic or an ischemic stroke? Because those are treated very differently. And if we don't see any bleeding, we do what's called a Cta Ct Angiography. And we do it right after the CT, and it shows us the blood flow to the brain. And is there a blockage? We can see that blockage.
Does that give you a good visual interpretation? You can see the blood going up into the carotid artery and then to the brain and see right where it stops?
So yeah, so before you could just see the vessels, but now you can actually see how fast the blood's flowing. So if there's a partially blocked artery, I can see there's a color map that shows, hey, there's not enough blood over here on the right side of the brain. It's too slow. Something's blocking that blood vessel.
Does it give you any other information, a CTA, the CT angiography, the blood vessel, the CAT scan of the blood vessel. Give you any other information about how much of the brain is involved, or how old the clot is, or anything like that?
It does. So the perfusion shows not only what part of the brain is not getting enough oxygen, but it can also estimate how much of the brain is permanently damaged versus how much is treatable or salvageable. And that's what I want to see. I want to see somebody who comes in who the brain's not getting enough oxygen, but it's all still alive. So if I go in there and open that up, they'll get much, much better.
So if you go in there and open it up, what you're going to do then is allow the blood to begin to flow again.
That's right.
And so the brain begins to get the oxygen that it needs. And the brain uses more oxygen than most of the body.
Any other part of the body, that's right.
So when you look at the CTA, can you pretty much get a good idea of, I think this is the perfect candidate, or
Yes.
is it going to be difficult, or is there ever two places that are blocked, or?
Sure. Sometimes there are two places. What it not only tells me if there is a blockage, but I can see all of the blood vessels from the heart all the way up. So I know what I need to do to get there, which tools I need to get there, how many curves I have to work around. And so it kind of gives me a roadmap of what I need to do next.
To me, that's just very, very exciting to listen to you talk about, planning to really save this person from a dysfunctional life, maybe even death, and get it where they can become active and productive again. So that's what an interventional radiologist, tell me what interventional neuroradiologist is.
So an interventional radiologist, and when I moved to Knoxville, I was an interventional radiologist trained to do procedures inside the blood vessels of the arms, the legs, the kidneys, the liver. And so interventional radiologists are trained to use cameras, imaging, radiology stuff to get little catheters up inside vessels into the organs and work on them. When I came here, there were no neurointerventionalists in Knoxville.
There were none?
None. And it struck me as odd. One day I was watching the news and there was a football player in Maryville, and I don't know who he was. I'd like to meet him someday, but he had a stroke on the field. He passed out on the field. And they had to transfer him out of Knoxville to be treated because he had an abnormality with his blood vessels in the brain. And I thought, why is there no one here in Knoxville that can do this? And so I left Knoxville and went back and got the additional training to be the neurointerventional radiologist. I was the first neurointerventional radiologist in Knoxville back in 2004. And that's someone who's trained to work on the blood vessels inside the brain. And it takes extra training because of the challenges that are presented just to get up into the brain.
I would think that'd be very, very, very thrilling and exciting to do. It sounds dramatic and storybook, but it's also one that requires a lot of skill, a lot of preparation. When you get in the neck, what do you do? And how do you get in the neck? How do you go after that clot?
So let's say someone's got a clot, they're having that ischemic stroke, the brain's not getting enough oxygen. I make the determination what's the easiest way to get there. Sometimes it's through the wrist, sometimes it's through the groin, but I put a very small needle, numb up that skin, and take a little catheter and I thread it in. And using an x-ray, I advance it all the way up using little wires that I can turn and catheters that have different shapes. When I look at that CTA, I decide which shape catheter I need, and I can pick the right tool to get up there into the neck, and then from there all the way up behind the eye and up into the very large distal parts of the brain to pull that clot out.
So you can actually go up along, must be very, very small?
They're tiny. So we can work on vessels that are 1-2 millimeters in size.
With the help of the x-ray, is it easy to know where you are? I guess that you can see the catheter as it's going up?
It is today, Bob. When I started, it was not. So the machines now give me a 3D map, and as I move that machine around, the pictures of the vessels turn on the screen. It shows me exactly where my catheter is inside that brain.
It's getting too easy.
It's not too easy, but it's getting a lot easier.
So when you get to the point where, oh, here we are, here's where the obstruction is, here's where the clot is, how does that catheter remove the clot?
So I have two ways to get it out. One's basically like a little vacuum. It's when I get that little catheter up there, I hook it up to a suction, and a clot gets stuck on the end of it, and I pull it out. And it's interesting, when I start to pull, I can feel it. It's almost like when you're fishing, when you know you have something on the line. When I start to pull it, I can feel it starts to vibrate. I know I've got a clot there, and I pull it out, and the clot will be sitting right there on the catheter.
What does that clot feel like when you get it out and you're examining it?
Sometimes it's like a jello type material, but sometimes it can be a hard rock. It depends on where it came from. It can come from the neck, they can come from the heart, they can come from other places in the body.
When that happens, does the patient recognize what's happened?
When they pull the clot out, they typically don't know there's a change, but when I ask them something, they'll realize all of a sudden they can do something. For example, if they couldn't lift their arm, I'll say lift their arm, and they'll go, oh wow, I can move my arm now, and they just realize at that moment that everything's going back to normal.
That must be amazing to see. I'm going to ask you about another story when we come back, and we'll learn more about intravascular thrombectomy, simply going up into the vessel simply and finding the clot and removing that. And we've talked about suction. We'll talk about the other way to do it when we come back. We're talking with Dr. Keith Woodward, and we've been talking about interventional neuroradiology, about if somebody has a stroke, you can actually go up in the appropriate artery, way up even to the back of the brain, and can remove a clot that allows the patient to have normal blood flow to renourish the brain. You and I were talking about a story about someone's speech when you were fixing a clot like that. Tell me that story.
Yeah, so he was having what we call the ischemic stroke, or a blockage, where there was a clot blocking the artery on the left side of the brain, and that controls your speech, your ability to make the words or know which words to say. And so he could not speak at all. And you ask him his name, and he would just look at you. And so went in from the groin, able to get a little catheter up there, did that little suction embolectomy, or suction to pull the clot out. And as soon as the clot came out, I knew I had the clot. As I was pulling out, I said, "Tell me your name." And he looked at me and he said, "My name is," oh my gosh, I can talk again. And then he started crying. He was so emotional. It was really a powerful moment for me personally, and a great case. And we see that more and more commonly, especially if the patient can get to the hospital quick enough.
Yeah, that's the key, and that time is brain.
It is, yes.
So if you can get to the hospital quickly, you can save brain by reestablishing the blood flow. Is that now? We put the little suction in there, and we sucked out the clot, and you can sort of feel it dislodging. What's the other way that you have of removing a clot?
So if it's a hard rock type of clot and I can't get it to come out that way, we have a little device that looks like a little basket, and I take it up past the clot, and then I open that basket, and it catches the clot and pulls it out as I pull the wire back.
Is that a more dangerous or difficult procedure than this getting up to a suction?
It's a little more difficult because it's a stiffer device, and so it can bend the arteries a little bit, and you may be more likely to have problems with that. But in all, they're pretty safe procedures.
And when you reestablish the blood flow, how does that make you feel when you see a patient talk, when you see them lift their arm, when you say they can then even see that if certain arteries are affected?
I feel like I've been blessed with the best job in the world.
Yeah.
I really do.
Yeah. If I've got time, maybe I could go back and be a neurointerventional radiologist.
There are hard times too, for sure. But
So let's talk about some other things that you do. This is the removal of a clot in somebody that's having a stroke. So we've got to recognize by FAST, facial asymmetry, one side droops, an arm being weak, speech being garbled or improper. So tell me about other procedures you do other than getting an ischemic stroke.
Sure.
Removed.
So we talked about ischemic versus hemorrhagic, where an artery is blocked versus where it's bleeding. It's kind of like I'm a brain plumber. Pipes are either blocked or they're leaking. So a leaking pipe is a totally different problem with different solutions that we can give.
So what causes the pipe to leak, the blood vessel to
The
leak?
very common things are high blood pressure, but aneurysms are also a very common cause of bleeding.
So what is an aneurysm, and are these aneurysms in the brain we're talking about?
Yes, so an aneurysm in the brain, imagine a weak spot on a tire where it starts to bulge out a little bit. That's what an aneurysm is. It's the artery wall has gotten weaker, and over the years it starts to bulge out. These grow over several years. They don't pop up overnight. But when they reach a point where they become too weak, they can burst, and then they bleed. And that's a big problem.
And then you've got a big problem.
Then we have a big
So if you find out that somebody's got an aneurysm, what does the interventional neuroradiologist do?
Right. I put on my other hat, and now I'm going to go try to close that artery. And so I take the catheters we talked about, same type of catheters, run those up into the neck, and then using that same camera, guide my little catheter right up inside that aneurysm, and I can fill it up with little platinum strings.
How big are those little aneurysms?
Those little aneurysms can be down to 1 millimeter.
A millimeter, so that's
Tiny.
That's tiny, tiny, tiny. So you can get, and you fill it up with the coils, or what do you do?
I have these little strings. They're 10,000ths of an inch thick. They're so tiny. And when I advance those up, it fills it up and seals it off. I also have little stents I can put across the aneurysm to shut it down, and little baskets I can open up inside the aneurysm to close it off. The goal is just to stop the blood flow inside that weak spot and let the artery heal.
So what you're doing is preventing the weakness in that artery from getting so weak that it bursts and bleeds, and then you got big trouble. So you can put the finger in the dike in the dam,
right. Yes,
and stop that from occurring. Are patients symptomatic? How do they know if they got an aneurysm?
if they have a ruptured aneurysm, the classic explanation is it was the worst headache of my life.
Yeah.
When I have someone who has survived a ruptured aneurysm, and once they've kind of recovered, tell me what happened. They can say, it was 3:42, I was reaching up to pick up a basket, and then all of a sudden the worst headache of my life. There's never any doubt, do I have a headache or not? They know when it happens.
Yeah.
Something really bad has just happened.
We used to call those a banger.
Yes.
Somebody, it just was terrifying.
Yeah.
If somebody has one aneurysm, do they usually have 3 or 4 somewhere else up in the brain?
About 15% of patients have a second aneurysm somewhere.
So
we look closely to find those others as well.
And you go find them and you fill the aneurysm up with these little threads, these little coils, let it heal up, and the patient lives happily ever after.
That's correct.
Anything else the neuroradiologist does, the interventional radiologist?
So we're also key in detecting those strokes. As we talked earlier about how important it is for, if you see someone having a stroke, to get them to the hospital. It's just as important for when you get to the hospital for me to know as quickly as possible that there is a blockage in that artery. I know we talked a little bit about the AI, the artificial intelligence, and that is a system we put in at Vista Radiology that has a computer looking at those scans. The moment that scan is done, that CTA is done, the computer's looking for that clot. And when it finds it, it wakes me up in the middle of the night. Alarms go off and I get the call that there's a clot somewhere. So now I can find these much, much faster than I could just 5 years ago.
Isn't that amazing? Because as we said, time is brain.
That's right.
So this allows you to get to where you need to fix it much, 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 much quicker.
That's right.
Gratifying part of medicine?
Again, I think it's the best job in medicine.
Yeah, I can see that in your face, and I can see how that would be somebody that's in a life-threatening situation, that what you can do is make them into a very functional person. Is there a follow-up that you do on patients that have had a stroke or that have had aneurysms? Do you have to re-x-ray or redo something later on?
So the thrombectomy we talked about, pulling that clot out of
Yes.
that blocked artery, those patients, typically the next step is just figuring out what caused that blockage and treating them. Maybe they have AFib, arrhythmia of the heart, and that caused that blood clot to break off and go to the brain. So we have to treat that separately with a blood thinner. But typically we don't follow those patients because preventing another stroke is just finding the cause and treating that. The aneurysms, on the other hand, we do watch those because A, they can get new aneurysms in the future, and B, sometimes those aneurysms can try to come back. It's very rare, but we watch them for about 3 years. We know after about 3 years they don't come back when they've been coiled or closed off.
And when they come back, is there any difference in treating it?
It's usually easier to treat it when it comes
Second
back.
time.
Yeah.
Keith Woodward, you're a great teacher. I've loved this show. I've loved learning. You're a great teacher. You've been able to teach us the new advances that can save people's life. And what a great feeling that must be. You probably do have the greatest job in medicine.
Thank God. I think I do.
Wasn't that fabulous? You're going to want to stay tuned. We're going to be talking about the adrenal gland. Where is it? What does it do? What does it do to protect you? It does a lot. And what are the dangers of atrial fibrillation? And what is atrial fibrillation? It can be dangerous in several ways. We'll talk about those and learn about those. You'll want to stay tuned. I want to thank Dr. Keith Woodward. Wonderful discussion on neurointerventional radiology, intravascular thrombectomy. I thought it was a fabulous discussion. Now, questions from you, the viewer, that I think will be important to your health. Question number 1. Dr. Bob, how does the adrenal gland protect the body? That's really an excellent question. The adrenal gland is very, very important. It sits on top of the kidney. So there's one on each side. It's triangular. There are several things that the adrenal gland does. It has an outside covering. We call that the cortex. The cortex in itself has 3 layers. Let's talk about what they do. One of the layers produces a substance called aldosterone. That's what helps regulate the amount of sodium that's in the bloodstream. Very, very important to keep the sodium at a proper level. One of the other levels of the adrenal cortex would be where cortisol or cortisone molecules are actually formed. And what they do is they help in the metabolism of proteins, fats, and carbohydrates. So they help when we eat those foods to regulate them to get to where the body can use those for energy. And then also in the adrenal gland on the cortex, there are medicines that are sex hormones. And these would be both female and male hormones. The male is deoxyhydrotestosterone. They're not as active as the hormones that come from the ovaries or from the testicles, but they do produce features of male and female hormones. The middle of the adrenal gland is called the medulla, and the medulla is where we have epinephrine and norepinephrine, and those respond to fright and flight. And that's when you come upon something, the adrenal medulla will squeeze down and you'll have extra muscle strength, extra acuteness in what you're doing. Like if you come upon a wreck, you may be able to pick up a car and throw it aside. Not really that good. But it really helps protect the body in times of stress. And so know that the adrenal gland is very, very important to your health. If the adrenal gland, that cortex, begins to get weak or fade away, it's what we call Addison's disease. And that's where people cannot regulate their sodium. They cannot regulate the metabolism of proteins and sugars, carbohydrates, fats. And so the people get really tired, really weak, and really sluggish. And they don't perform well. They'll stand up quick and sometimes faint, and they just don't have any energy. The doctor will pick that up as he looks at different tests that are available. Question number 2. Dr. Bob, why is atrial fibrillation dangerous? Well, let's talk about atrial fibrillation. We mentioned it once in the show with Dr. Woodward. Atrial fibrillation is a condition where the atrium, there are 4 chambers to the heart. The chamber that we're looking at is the left atrium, and that left atrium, if it begins to wiggle instead of beating like this, actually it can beat 300 times a minute. It's going real, real fast. It goes so fast that the blood can't be squeezed into the next chamber. And every time the heart wiggles, it tries to send a message to get the rest of the heart to pump. It only can beat as fast as it can receive those. And so the heart rate is irregular, and it's irregular on an irregular basis. So we call it irregularly irregular. It's like beat, 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 beat. Here's one of the problems. The rate can be very fast. Sometimes it's very difficult to control. Sometimes the heart rate is so fast that the heart doesn't have time to really fill. And so we really don't get good exchange of the blood, and the heartbeat is not an effective heartbeat. The other part of atrial fibrillation is the heart is wiggling, that left atrium, and actually the blood can become stagnant in there. It's not moving fast enough, especially one little area called the appendage. And blood clots can form in there, and those blood clots can come loose, go from the left side to the big pump on the left, and go up and cause a stroke. As a matter of fact, 25% of strokes are due to atrial fibrillation. And intravascular thrombectomy is one of the ways we could remove that clot from occurring. That's all the time that we have for this show. Remember those 4 things that we like to talk about. Number 1 is exercise. It is so important for your health and for your life. It reduces stress. It helps us lose weight. It helps our heart beat stronger. It makes us sleep better. So the importance of exercise can't be overlooked. 7.5 to 8 hours of sleep. If people don't sleep well, they don't perform well. The brain has to get renourished, rejuvenated, and it does that during sleep. And so your 7.5 hours is important. Some people say, oh, I can get by on 4 hours. That's not correct. If you're only getting 4.5 or 5 hours sleep, you're not getting enough, and it will show up in your actions and in your speech and in your personality. Be sure that we eat well. Remember, more fruits and more fiber, and you'll be a healthier person. It'll help your weight be more regular, and you'll be a happier person. And most of all, what is it we like in that Dr. Bob Show? That's that laughter in your life. You know, sometimes we don't laugh enough. We don't find that person. We can tell funny stories and we can giggle about the crazy things that have happened during life. And there's so many things that we can laugh about. As we watch television, as we go out and get the mail, there's always something that we do. And if you can laugh at yourself by something funny you've done, well, then it even makes it better for everybody. So remember to have that laughter in your life and you'll stay healthier.